I'm here to present a case about a 12-year-old girl, Kritika, from Chinnapalayam, whose informant is her mother and reliability is good, from lower socioeconomic class, came to OPD with, next slide, ma'am. Chief complaint of cough with expectoration for 7 days, fever for past 3 days, and difficulty in breathing for past 3 days. Next slide, ma'am. History of presenting illness, cough, which was for past 7 days, which is acute in onset and productive cough, as food terms moderate in quantity, white in color, mucoid consistency, not foul smelling, and not blood-stained. Next, ma'am. Fever for past 3 days, which is high-grade fever, intermittent in nature, not associated with chills and dry gas, response to paracetamol. Breathlessness for past 3 days, which persists throughout the day. History of decreased appetite present. History of not gaining weight present. Next, ma'am. No history of chest pain, wheeze, blood-tinged sputum. No history of throat pain, ear pain, running nose. Now the child has admitted and had been receiving treatment for 3 days. Next, ma'am.
Okay,
Past
can we
history.
start here?
Yes, sir.
Okay, what is your differential diagnosis based on this short history?
Sir, cough, fever, breathlessness can be associated, can be think in terms of pneumonia, empyema, sir.
Okay, in what way? Why you are saying empyema?
Fever present, sir.
So, okay, apart from that, so the child is having fever, cough, and breathlessness. Which one is predominant right now?
Cough, sir.
Cough is predominant right now. Fever is not a predominant complaint.
No, sir.
Fever is not a predominant complaint. In the absence of fever being not a predominant complaint, is it correct, right enough to brand it as a case of pneumonia? You just open it up. It is up to you. No issues.
So this cough with expectoration, sir. So this cough with expectoration, sir. So primary complaints is cough and fever, sir. So it could be a stage of simple pneumonia, sir, at this stage. Apart from this, it could be.
Is there any term called simple pneumonia?
No, sir. There's pneumonia, severe pneumonia, and very severe pneumonia, sir.
Okay.
So it could be a simple lower respiratory tract infection, or it could be bronchiolitis or bronchitis also.
Okay, please. This is a 12-year-old girl, my dear boy. Okay. So we are not supposed to say the diagnosis of bronchiolitis here. Okay, bronchiolitis, you need to use the term either first episode wheeze or wheeze that occurs in children less than 2 years. Please do not use the word bronchiolitis in a 12-year-old child. Okay, so this child presented with the fever, cough, breathlessness. Okay, and you had added a fever response to paracetamol. Is there any thing that you want to say with this history, response to paracetamol? What do you mean by response to paracetamol? You had added response to paracetamol. So is there anything you need to add with respect to this response to paracetamol? Whenever you want to commit something, you need to have an underlying diagnosis or underlying something to say. Is there anything with respect to this response to paracetamol?
Sir.
I don't think so. Okay, I don't think you need to add the word response to paracetamol. Point number one. Second point, this is an acute history and you had added not gaining weight. In this 1 week, how can you expect a child to gain weight? Second point, I don't think, we don't think you need to add that the word gaining of weight is not, is present or not. So first point, response to paracetamol is not necessary. Gaining weight is not necessary. So your predominant complaint is fever. Okay, predominant complaint is fever. So by and large, usually it is a viral fever or bacterial fever. Is there anything clinically to differentiate between a viral fever and bacterial fever? As an undergraduate, you mean?
Sir, bacterial fever presents as high grade fever, sir.
Okay.
Sir,
Dengue is a viral fever. It usually presents with high-grade fever.
It will be intermittent in nature, sir.
So
Oh, it has got
basically,
something to do with the onset of onset, how the fever will be, and as the days goes, how the fever progresses. That is what Dr. Sarath is asking. Is there a difference between onset and how the fever progresses?
the
Ma'am,
main
in
difference
bacterial,
between bacterial and viral fever.
so in bacterial, the child will be toxic throughout the day, sir. Whereas viral, a child will be
Very good. Very good.
toxic for a while and then plays for some time and again comes with complaints of fever and tiredness and lethargy.
Very good. Very good. Then, very good. So usually
Sir,
a bacterial.
viral fever.
Yes, Naushad.
Sir, viral fever will be mostly suddenly in onset, sir, whereas bacterial isn't.
Okay. See, usually a viral fever starts with, as madam told, usually viral fever starts with a high-grade fever. As the day progresses, by about the 4th or 5th day, majority of the viral fever will regress. Whereas bacterial fever, unless otherwise, if it is not treated properly with appropriate drugs, it shoots on. Point number 1. Second point is, in between fever, after paracetamol, the child will be playful. But as far as the bacterial fevers are concerned, even after giving paracetamol, the child will tend to be toxic. Second point. Third point, usually viral involves more than one area or more than one system. That means usually a viral fever will have a coryza, running nose, cough, breathlessness. It means it involves the entire respiratory system. At times, it may or may not be associated with other symptoms such as your gastrointestinal tract with the manifestation of diarrhea, whereas bacterial fever is usually a localized fever. Okay, either acute otitis media, ear pain, sinusitis, or throat pain, or tachypnea, manifestation of pneumonia. So basically, for an undergraduate, first, if any fever comes to you, the first thing you need to classify is whether it is a viral fever or bacterial fever. As we discussed, viral fever starts with a high-grade fever. As the day progresses, it usually reduces. The child will be playful in between. Second point. Third point is, as you said, the response to paracetamol may be present. Fourth point, it usually involves either one system as a whole or it involves more than one side. Whereas bacterial fever slowly, gradually shoots up. Point number 1. Even after a paracetamol, the child will continue to be toxic. Point number 2. Third point is, it is a localized one, because as an undergraduate, majority of the times when you sit in an OP, you tend to write an antibiotic such as amoxicillin along with a CPM. So majority of the cases that are seen by you in your OP practice is viral. So if it involves more than one system, if it gradually reduces, do not write an antibiotic. Okay? Venkatesh, do you want to add something here with respect to fever, ma?
Yeah. I think whatever you said, I totally agree with that. So I think you've driven the point very well. The important clue, like Sharath said, is in between fever, if the child is well and is playful. That is an important clue to say that that could be a viral infection. And as Dr. Sharath rightly put it, the involvement of multiple systems. For example, the child can have coryza, they can have conjunctivitis, rhinitis, the child can have some amount of diarrhea, the child can have some rash. So those things favor a diagnosis of viral infection. So viral infection is most of the time insidious. Bacterial infections are usually sudden. They are abrupt in presentations. They are more toxic, like Kaushik said. They appear more toxic. So I think, those are the things that I would like to add.
And also one point to all our presenters, where you said cough and you use the word expectoration. So as an undergraduate, whenever any child comes with cough, what are all the types of specific cough by which you can make a diagnosis? As an undergraduate, you need to know what are all the types of cough. What do you mean by dry cough? What do you mean by wet cough? What do you mean by cough with expectoration? And is it possible to get a diagnosis based on the nature of cough?
Dry cough is the cough where it will not be associated with sputum, sir. Mostly it is due to upper respiratory tract infection, whereas lower respiratory tract infection usually presents as wet cough where there will be sputum production, sir. And
I think that is, I mean, I cannot be so very dogmatically said, because when you have running nose and a lot of postnasal drip, you will have a wetness to your cough. Okay, so, and similarly, when you have tuberculosis of the lung, you may have only dry cough. So just because it is wet cough, it doesn't always say it is a lower respiratory tract infection. Yes. And you know, the vice versa also. So you can characterize cough by the amount of sputum produced, the character of the sputum, you know, the smell, whether it is associated with hemoptysis or something like that. So those give you much more information, whether it is you know, about the underlying pathology. And if cough is associated with fast breathing or chest indrawing or noisy breathing, then I would attribute it to a lower respiratory tract. I mean, the origin of cough to be from the lower respiratory tract, rather than just based on wetness and you know, dryness. Yeah, I think maybe Sharad can give us comments on this particular, because many students continue to tell we need to. What do you think about this, Dr. Sharad?
Yes. So usually, as you rightly said, usually we don't use the term expectoration. In pediatrics, you use the term wet cough or dry cough, because majority of the time, in your case, it is an adolescent girl, so it will be possible for her to expectorate the sputum. But majority of times in pediatric age group, you cannot expectorate the sputum. That's why the term wet cough is used instead of dry cough. Point number one. So please use the term whether it is a dry cough or wet cough. Okay. So whenever you see a wet cough, second point, whenever you see a wet cough, as Venkatesh sir told, it can also be due to a postnasal drip or acute viral coryza or a sinusitis. So in that instance, how to differentiate between a wet cough that is due to an upper respiratory tract infection or wet cough that is due to a lower respiratory tract infection, that is a sign of a lower respiratory tract infection like pneumonia. So whenever you have a wet cough along with noisy breathing, that noisy breathing can be due to stertor. Stertor means what? That noisy sound that you hear because of the presence of secretions in the nose. That is called stertor. S-T-E-R-T-O-R. Second point, when you have snoring, it can be due to an adenoiditis. Okay. Third point, it can also be due to some infections in and around the epiglottis, or usually you don't have that kind of cough. Usually your acute viral coryza can present with wet cough, your sinusitis can present with wet cough, or your adenoiditis usually presents with a wet cough. So wet cough with fever with noisy breathing must be due to an upper respiratory tract infection, whereas wet cough, high grade fever without any noisy breathing but with much of tachypnea can be due to a lower respiratory tract infection such as pneumonia. This is regarding about dry cough, a wet cough with respect to upper and lower respiratory tract infection. So look at the noisy breathing, look at the presence of tachypnea. So with the noisy breathing, high grade fever, toxic can be due to upper respiratory tract infection. Without much of noisy breathing, with the less cough and more of tachypnea can be due to lower respiratory tract infections such as pneumonia. Second point. Third point, with respect to apart from this, what are all the types of specific cough? So that after hearing the nature of the cough, you can get a diagnosis.
For example, barking cough. No, barking cough is pathognomonic of some condition. They don't know.
So whooping cough can be there in pertussis, sir.
Very good, very good. So whooping cough. Whooping cough suggests you of what?
Pertussis, sir.
Pertussis. Is it possible to imitate a pertussis cough from your side? Because it is a spotter. Is it possible to imitate? You imitate like Varnamayaram Surya in your hairstyle. In the same way, is it possible to imitate pertussis cough?
Try. Give a try. No?
Just try. We will have a jolly discussion. This is not an examination per se. We are discussing, that's all.
Something of that nature.
Okay,
So
so
that,
it is here. Okay, good try, good try. Any other, any of your friends? Any of your friends here?
No, he's asking you to show a whooping cough.
Naushad Khan. So, yes, boss.
Gogan try பண்ணுங்க. Inspiration prolonged இருந்தா அந்த இது வரும். whoop sound வரும்.
So, in a case of pertussis, usually you have a serious bouts of cough. Gap விடாம ஒரு நிமிஷம் இரும்புவீங்க. எப்படி இருப்பீங்கன்னா இப்படிதான். So, இந்த மாதிரி ரயில் மாதிரி bouts of cough without any gap will be there, followed by post-tussive vomiting. Post-tussive vomiting na இரும்பி வாந்தி எடுக்கிறது. Third point, எனது whoop இரும்பி ஒரு மாதிரி கேவிட்டு போறது. எப்படி? இதான் whoop. So, as a undergraduate, whenever you see any case of cough, you look at these 3 points. First point enna? Paroxysmal cough. Paroxysmal na enna? திடீர்னு இரும்புறது. It comes and goes, it comes and goes. Paroxysmal chains of cough without any gap in between. That is called paroxysmal. And then it may or may not be associated with post-tussive vomiting. It may or may not be associated with whoop, because now and there we have been seeing cases of pertussis. Point number 1. Where do you have any other specific coughs? 1, as you said, paroxysmal. 2, 1, as you said, pertussis. 2, what are all the other types of cough? Let us
barking cough. So barking cough can be an epiglottitis.
Epiglottitis, usually listen, usually in case of epiglottitis, you have a triad of dysphonia, dysphagia, and drooling of saliva. Epiglottis do not have any cough receptors, as a result of which in epiglottitis you do not have significant cough. So whenever any child comes with cough as a predominant complaint, your diagnosis should not include epiglottitis. Okay, instead you come down. That is the clue for you. Instead of epiglottitis, you come down. What are all the other structures below the epiglottis?
So laryngitis.
Very good. Laryngitis, நாய் மாதிரி இரும்புற கல்னு இரும்புறதுதான் laryngitis. So in laryngitis, you will have a barking cough. So whenever any child comes with barking cough in a pediatric age group, what will be your differential diagnosis? In pediatrics, sir, first 2 days my child had a running nose. Now for the past 2 days my child has been coughing like a dog. Now a little bit of sound like I am hearing from my child's throat. What is the diagnosis?
So what is that inspiratory sound? What he told
What
now?
is the sound called?
அதுக்கு என்ன பேர் அந்த சவுண்டுக்கு பேர் என்ன? What is the inspiratory sound?
Stride.
Very good. Strider. So when you have a barking cough with the stridor with the low grade fever, what is the possible etiology that can be made out with respect to this history in pediatrics age group?
Croup, sir.
Very good, very good. ALTB or croup, laryngotracheo bronchitis. Fantastic. So you told barking cough, you told about paroxysmal cough. What other coughs you know?
Bovine cough.
Brassy cough, sir.
Okay, what do you mean by brassy cough or metallic cough?
Sir, any space occupying lesion or aortic aneurysm compressing on can cause metallic sound or bar.
Very good.
Brassy cough.
Any extraluminal compression of trachea. In pediatrics, we don't see much of aortic aneurysm. In pediatrics, you need to say two diagnoses: a mass such as a mediastinal node or a vascular ring. Okay, or a vascular ring, an abnormal vessel surrounding the trachea. Okay, so this is your brassy cough. What else you can have? So you
Bovine
told me
cough.
cough. What else?
Bovine cough, sir.
What do you mean by bovine cough? Even though it is there in the literature, we don't see much of bovine cough in pediatric age group. If it is so, what is a bovine cough and what are all the differential diagnoses?
Any tumors compressing recurrent laryngeal nerve can present.
Very good. Okay. So usually recurrent laryngeal nerve palsy can. What do you mean by that bovine cough? See, whenever you cough, tell me.
There won't be explosive nature of the cough.
Fantastic, fantastic. So whenever you cough, it should be so instead it means it is a bovine cough. As you said, recurrent laryngeal palsy can occur as a result of PDA ligation surgeries in pediatrics. Okay, what else then? So you told paroxysmal cough, you told bovine cough, you told brassy cough. Very good. Then what else? In pediatrics, sudden onset cough unless otherwise proved is dash.
Foreign bodies.
Fantastic. This alone is more than sufficient for this class. So foreign body. Very good. What else you can have? What else? Coughing with the feet. Very good. Coughing with feet. Sir, my child is coughing whenever drinking something or eating something. So whenever you have cough with the feet, what are all the differential diagnoses? This is very, 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 very important in pediatric age group.
So GARD can present, sir. Doric.
Okay, GARD accepted then. But we don't think so. But GARD is a relatively reasonable good diagnosis then.
Aspiration.
We can't get you, Pa?
Aspiration, sir.
Yes, aspiration only. What is the cause? Aspiration is the symptom. What is the cause?
It's a cleft palate.
Very good, very good. Fantastic. Even recently, 4 days back, a mother came and told us, my child has been coughing like anything. Okay, since birth. Since birth, that child is 1 year, admitted thrice for recurrent pneumonia in a medical college. All extensive investigations had been made and it was referred to ICH. One of our postgraduate presented when we asked, is there any history of aspiration? He told, yes, sir. Have you examined the oral cavity? He told, yes, it was normal. But when we again examined with a gloved finger, there was a cleft palate very deep inside. So the mother was so clear. The mother told us that whenever my child eats, particularly drinks, it comes out through nose. So it doesn't mean that you need to inspect, you need to palpate and see inside the deep soft palate, because so often a cleft palate is also missed even by a doyen in our field. So always inspect the palate. Fantastic, very good. What else? So you told GER. There are so many causes, but as far as undergraduates are known, GER is a good differential diagnosis. Submucosal cleft palate is a good diagnosis. What else? An abnormal communication between the swallowing tube and breathing tube.
Tracheoesophageal.
Very good. What is that? H-type tracheoesophageal fistula. Okay?
Yes, sir.
So very good. So coughing with the feet is a very great history. You need to elicit. Right. Apart from that, so let me mimic a cough. Let me see whether you are going to diagnose or not. So you just listen to me. So a 3-month-old infant is coughing like this. Is it possible to tell a diagnosis by identifying this? So the child is coughing for each and every breath. What is that?
Foreign body.
Huh?
Like a typewriter sound.
What is this?
Foreign body, sir.
No, my
It's
dear
3 months
boy.
old.
3 months old baby. Cough for each and every breath.
One more
This
clue
is-
you give, Dr. Sarath. Innoru clue கொடுங்க.
இதுவே clue தானே madam.
Sound is like a typewriter sound. So usually it is called by name staccato.
Staccato cough. So as Venkatesh sir rightly told, staccato cough. So in which disease you will get staccato cough?
Any atypical organism?
From Legionella myco.
Have you not heard about chlamydia, my dear boys and girls? Chlamydia? Chlamydia, have you not heard about it?
Yes, sir.
Hogan, Kaushik, Naushat, had you not heard about this chlamydia?
Yes, sir.
So whenever you have this kind of cough with each cough with each breath, it is called staccato cough, as Venkatesh sir told, and it occurs in chlamydial infection. You need to suspect in a early infantile period. Whenever any child comes with cough, this kind of cough with Krebs but non-toxic. Okay, whenever you hear Krebs, invariably you will tend to start an antibiotic like ceftriaxone. But in this case, you need to give an atypical coverage like macrolide. But that is not all for you. So now what you have learned about these types of cough, you tell me. Anyone summarize? Naushat? Naushan Khan, you tell me, dear. We had discussed about various types of cough. Now you just summarize.
சொல்லுங்க கோகன் ரிப்பீட் பண்ணுங்க.
Yes, ma'am.
சொல்லுங்க 1 2 3 சொல்லுங்க.
Ma'am, brazy metallic cough we will get an aortic aneurysm, ma'am, or any intrathoracic space operations.
சரி பரவாயில்ல அப்புறம்.
Cough in pertussis or
barking cough in epiglottitis, ma'am.
No. Barking cough in, he corrected you. No?
Laryngitis.
Laryngitis.
Croup or acute laryngotracheal bronchitis.
Bronchitis.
அப்புறம்
bovine cough in Any tumors compressing recurrent laryngeal nerve.
Hmm.
Staccato cough in chlamydial infection.
Cough during feeds.
Cough during feeds. We should think of submucosal cleft palate, chlamydial infection. Chlamydial infection.
Chlamydial வராது. Cleft palate அப்புறம்
Tracheoesophageal fistula.
yes,
Very
tracheoesophageal fistula. GERD. Yes, good.
And also in a cerebral palsy child. Okay, and also it is more common in a child with cerebral palsy. Okay, because they don't have that good palatopharyngeal coordination. Okay.
Yes, sir.
Okay. So with cough, with toxicity, with tachypnea is lower respiratory tract infection. Can you tell me other causes for dry cough?
Sir, pharyngitis.
Accepted. Then accepted.
Laryngitis.
Accepted.
Sir, tuberculosis.
Okay. Dry cough. Asthma is often a dry cough. Pertussis is often a dry cough. Okay. Asthma is a dry cough. Pertussis is a dry cough. The mother says, sir, no cough at night. Cough only in the daytime. Otherwise, the child is playful. It has been there for more than 4 weeks or 8 weeks. Many drugs are tried. Nothing works, but my child is doing well. X-ray taken normal. Inhaler taken normal. ATT taken. Despite all this, my child has been coughing. No weight loss. X-ray normal. Multiple drugs tried, but the child is coughing. What is this called? So whenever everything is normal, but a complaint is present, what you will call it as?
Habitual cough.
Functional. That means habit cough. That is otherwise called honking cough. What is that? Honking cough without any sleep disturbance, without any toxicity is habit cough. But that is also a dry cough. Okay?
Yes, sir.
So now in this discussion, you know what are all the causes for dry cough, what are all the causes for wet cough, reasonably how to differentiate between an upper and lower respiratory causes for cough. Okay, so right, what else? So in this child you have fever, you have cough, you have breathlessness. Now you tell me what are all the causes for breathlessness?
Sir, could be respiratory cause or cardiovascular cause, sir.
Okay, how to differentiate between a respiratory cause and cardiac cause?
Sir, in respiratory cause, the breathlessness will be there throughout the day, sir. Whereas in cardiac cause, whenever there is effort intolerance, the child will be breathless, sir.
See, simple, one point. Respiratory system, unless otherwise proved, it will be always associated with cough. So whenever your breathlessness is associated with cough, predominantly you need to think in terms of a respiratory tract involvement. Okay? So first point is cough. Okay, what else you can ask? What else you can identify? How to differentiate? What other causes? Usually in adults.
What are the associated symptoms, Gogan?
Chest pain, palpitation. In new child, there will be presence of success cycle in case of cardiovascular cause of breathlessness.
Are the infancy la older child la?
Child will present with forehead sweating, chest pain, palpitation.
Fatigability will be there.
Okay.
exertional breathlessness, like somebody said, exertional breathlessness, palpitations, dependent edema. So, and orthopnea, paroxysmal nocturnal dyspnea, those kind of things, if they are associated with breathlessness, you tend to think of cardiac cause for the breathlessness. Whereas if only cough is there and there's only fast breathing or chest retraction is there in addition to the breathlessness, and if there is any variation in the symptoms in relation to particular posture or something, then I mean, on lying down, if it is more on one side, or those things tend to give a clue to the respiratory cause.
Okay, so from this history, you tell me whether this is a bacterial etiology or viral etiology. And you have, is there any history of chest pain?
No, sir.
If at all there is a history of chest pain, how to differentiate between a cardiac cause and pulmonary cause?
Sir, first point is site, sir.
Very good.
Sir, then
what do you mean by that site?
Sir, if the chest pain present at center of the chest, mostly we will think of cardiovascular cause, sir.
Very good. Precardial pain is suggestive of cardiac cause. Very good. Then,
sir,
the chest pain on exertion can be cardiovascular cause.
okay, accepted. Pericarditis. Then, so it is central, increases with the inspiration. What about pulmonary cause?
pulmonary cause, chest pain due to pulmonary, it will be mostly pinpoint type of chest pain, sir. The patient can usually point out the area, sir.
எங்க point out பண்ணுவாங்க? Where they will point out?
Sir, over the lung areas, pulmonary areas.
Lung area is between here to here, here to here, where they will point out.
See, what is the pulmonary cause for chest pain?
Pleural effusion.
Now you tell the answer. Try to connect it.
Pleura, is it in the central site or peripheral site? Medial or lateral? Lateral. So often medial site, often a cardiac, whereas lateral chest pain often a pleural etiology. Okay?
Yes,
so
sir.
often a pleural etiology. Okay, so central chest pain, cardiac. Lateral chest pain, so often a pleural etiology. Okay? Then,
Yes, sir.
is there any chest pain in our case?
No, sir.
No. You told empyema as your diagnosis, na?
Yes, sir. Yes, sir.
You told empyema as your diagnosis. Usually in this age group, empyema, whether it is a TB or bacterial empyema, will be associated with a chest pain. Here it is not so. So
Yes,
from history, fever is there, cough is there, breathlessness is there. Breathless means you mean tachypnea. So is there any noisy breathing in the form of snoring or stridor?
No, sir.
No. So then it is an upper respiratory or lower respiratory?
Lower respiratory.
Very good. So it is first point. Is it bacterial or viral? It was discussed, na? The child
Yes.
was admitted on 5th or 7th day of illness. That means what?
Bacteria.
Is it improving or worsening?
Worsening, sir.
As the time goes, if the child worsens, is it bacterial or viral?
Bacterial.
Bacterial. First point. Second point. Now you tell me, is it upper respiratory or lower respiratory?
Lower respiratory.
Why? Because there is no significant noisy breathing. And you told breathlessness. So more in favor of a lower respiratory tract. Third point. Is there any pleural etiology?
No, sir.
No, because there is not much of chest pain. Now, is it alveoli or interstitium?
Alveoli.
Why alveoli? If alveoli means, what is the pathology? The child is admitted with fever, alveolar involvement. What is your diagnosis? Consolidation, pneumonia. Okay. Usually in interstitial pathology, you don't have much fever, but here you have a alveolar involvement, probably a consolidation. So this is a bacterial fever involving the lower respiratory tract, more often an alveolar pathology. Is it possible to get a close diagnosis from this basic history? Yes or no?
Yes, sir.
Yes. So can it be a pneumonia now, you tell me?
Yes, sir.
Yes. Satisfied?
Yes, sir.
Yes.
Venkatesh, from your side, you want to add anything?
Yeah. So the point is, we need to find out what we are dealing with from the initial part of the history. Only then we can build up the case and have a proper differential diagnosis. The aim of taking a history is to arrive at a logical conclusion from the history itself about which organ system is affected, what is the pathology, what is the likely etiology, what is the complication that you expect, so that from the history itself we can make some of the differential diagnosis, so that it helps you when you go to the examination to do a focused examination pertinent to what you have arrived at from the history. So like Dr. Sharath said, it is important to train your mind to look at what is the diagnosis from the chief complaints. So only then you know what history to ask for in the other things of the history, like past history, what to ask for, then to find out the etiology, what else to ask for, to find out what is the course of the disease, what is the treatment given, is there any response to treatment, does it give a clue to the diagnosis, like did the child receive any nebulizations in the past, did the child receive any kind of chest therapy, or did he take prolonged antibiotics frequently, did the child get hospitalized frequently, so those kind of things. So if you don't have a diagnosis from the chief complaints, it becomes very difficult. So then we will be taking history only for the sake of taking history without actually analyzing what the symptoms tell us, right?
Yes.
So yeah, so now since you made a diagnosis of a probable pneumonia from the chief complaints, then you need to go back and find out, like, is this only the first episode, or the child has been having recurrent episodes? What is contributing to this recurrent episodes? So then we'll have the question like, what is recurrent pneumonia? When will you call it as recurrent pneumonia? Or did the child have any time had a persistent pneumonia? What is the difference between persistent pneumonia and recurrent pneumonia? What usually happens to these children as a consequence of this pneumonia? Do they develop any abnormalities in their lungs? Right. So that is how we need to build up this case now. So can you narrate now the past history and tell us what information you get from the past history, which helps us to further take this case for the next level of discussion.
Yes, sir. The child was apparently normal before 3 years of age. At 3 years of age, child presented with cough, fever, and breathlessness, got admitted and received some treatment, got all right. At 4 years of age, child diagnosed to have intestinal obstruction, got treated in a private hospital, diagnosis, worry intussusception, surgery done. At 6 years, admitted for cough, fever, and breathlessness, and got treated. Next slide.
So what information you get from the history which you just told us?
The
What do you
child
think?
recurrent, that's recurrent respiratory tract.
So when will you call it as recurrent pneumonia? What is the difference between recurrent pneumonia and persistent pneumonia?
More than 3 episodes per year, which requires hospitalization, we tell it as recurrent pneumonia, sir.
More than two episodes in a year, or more than 3 at any time period?
Yes.
Or 3 or more at any time period. Okay, so that will be recurrent pneumonia. But what is the basic necessity to, why should we talk about recurrent pneumonia? What happens in between the pneumonia to the child?
The child will be free of symptoms.
Yeah, so we need to ensure between the episodes is the child free of symptoms. Okay, so that will tell you that it is recurrent pneumonia. Sometimes the child might have persistent symptoms. You may not fully recover from one episode of pneumonia to the other episode of pneumonia. then we call it as persistent pneumonia,
Persistent
right?
pneumonia.
So what is the definition of persistent pneumonia?
Yes, Gogan, how many weeks, more than how many weeks you call it as persistent pneumonia?
More than 6 weeks.
More than
Really?
4 weeks.
4 weeks.
Yeah. So if the symptoms are persistent for more than 4 weeks, and there's no, respite in spite of your treatment, as a child continuing to have symptoms, and there is radiological findings are persisting, then you call it as persistent pneumonia, right? So in this child, it looks like the child is having a recurrent pneumonia, and child also has some GI problems, isn't it? Child
Yes,
had
sir.
some intestinal obstruction, child got operated. So can we have some connection? Why is the child having a respiratory as well as GI problem? What are the possible things you will think of if a child has respiratory and GI problems?
Sir, at this stage, it is not relevant, sir. But in bronchiectasis, for which one of the reason is cystic fibrosis, the complication of interception can be think of.
Okay. What else you expect in cystic fibrosis? Is interception common or something else is more common?
Sir,
Distal
recurrent
intestinal
respiratory
obstruction.
Pardon?
malabsorption.
Malabsorption symptoms. Yeah. So malabsorption symptoms, recurrent diarrhea, those kind of things. Failure to gain weight.
Yes.
So those things would be more commonly seen rather than other causes. Yeah. So what are the other etiologies you should explore when you have a child with recurrent pneumonia?
Sir, it could be due to respiratory cause like congenital anomalies with sequestration lung or bronchial cyst, or it may be due to bronchiectasis, or it may be due to cardiovascular cause where child may suffer with congenital asymptomatic heart disease with increased pulmonary flow, or otherwise systemic cause like immunosuppression.
Yes. So we need to differentiate whether there is a congenital anomaly or malformation, whether there's a congenital acyanotic heart disease with left-right shunt lesion like your ASD, VSD, PDA, or it could be due to mucociliary clearance disorder like your cystic fibrosis or primary ciliary dyskinesia. It could be due to immunodeficiency, whether it is congenital or acquired, right? Or sometimes it could be just a episodic viral infection which is producing some lower respiratory symptoms like your viral infection induced wheezing or asthma. Sometimes they also can present like this. The child can have fever, cough, cold for 3-4 days. They can have breathlessness. Once they are nebulized, they get better and they become all right, isn't it?
Yes.
So those things you should consider as your differential diagnosis for recurrent pneumonia.
Yes.
Yeah.
At
Go ahead.
age of
Yeah.
At age of
Only
8,
one
yes.
final point to add. Gugan Kaushik now said one question. See, the child was admitted so many times. Okay, how
Yes, sir.
do you say that they are all recurrent pneumonias? I may say it can be due to recurrent asthmatic attacks requiring nebulization. So in history, whenever any child admitted with a recurrent admissions with respect to respiratory involvement, how do you say that it must be probably due to pneumonia?
Sir,
Without analyzing because majority of the times they will have their discharge summary. In the absence of discharge summary, is it possible to analyze? Is it possible to say those recurrent admissions must be due to pneumonias rather than an interstitial lung disease, rather than an asthmatic attack? How do you say so?
Sir, history of fever.
Fantastic. Then,
Sir, the failure to thrive, sir, child in case of asthma, it won't be much.
very good, fantastic, well accepted. Great point, great point. Yes, then. So each and every time, whenever any child is getting admitted with respiratory distress, what are all the basic things you need to ask in history? Point number 1, fever. Point number 2, cough. Point number 3, breathlessness. So
Yes,
you
sir.
need to ask the mother, ma, which one is higher? Which one to
Okay.
you is predominant? Is it fever? Is it cough? Is it breathlessness? ஒரு வாட்டி அட்மிட் ஆகும்போது எது உங்களுக்கு அதிகமா இருந்துச்சுன்னு you need to ask the mother. Okay, don't put a leading question. Let her open out. Mother is usually, she's always correct. That is what the pediatrics taught us. Mother is 100% correct. When you say mother's reliability is good, I don't think whether we need to say that word or not. Mother is always correct as far as pediatrics is concerned. So whenever you have fever, cough, breathlessness, you need to put the mother. Amma, which one is higher? Fever is higher, cough is higher, or breathlessness higher? You need to ask the mother. So based on this fever, cough, breathlessness, how can we reasonably get a differential diagnosis without looking into the discharge summary?
சொல்லுங்க கோகன், சொன்னீங்கல்ல, அதை ரிப்பீட்
Mm.
பண்ணுங்க.
History of fever, history of failure to thrive, which what is the predominant symptoms?
Okay, so okay, tell me what are all the, yes, as you said, failure to thrive is a well accepted point. It will not be there in an asthma. Great point, great point. Second, fever, yes, more in favor of pneumonia. What else?
Sir, periodic exacerbations. So asthma mostly comes in attacks and the way of cough, sir.
Any seasonal variation will be there, which will have more seasonal variation.
Asthma,
Some triggers will be there for which condition?
asthma.
And any long-term treatment, inhaler therapy is for which condition?
Asthma.
Okay, see, whenever you have recurrent cough and recurrent breathlessness without fever, without failure to thrive, probably you are dealing with an asthma.
Yes, sir.
Okay,
Yes, sir.
whenever you see a case of recurrent cough and recurrent breathlessness, probably you are dealing with a case of asthma. Point number one, because asthma is a disease of airway. Okay, airway
Yes,
contains cough receptors. Asthma is, other term for asthma is bronchitis. Bronchitis means inflammation of bronchus, which will manifest as cough and breathlessness as the predominant complaint. So when mother says, sir, my child's problem is not fever, usually she gets admitted with recurrent cough and breathlessness means you are dealing with a case of asthma. Point number one, clinically. Okay, second point, whenever a child is admitted with recurrent breathlessness without any much of fever, without any much of cough, what will be your differential diagnosis? You catch my point? A child is getting admitted with breathlessness alone, but not much of cough or not much of fever.
interstitial lung disease.
Fantastic, very good, greatly appreciated. Interstitial lung disease, because in interstitium you don't have any much cough receptors.
Cough receptor.
Interstitium you don't have any infective etiology to present in a recurrent matter. Brilliant point. So recurrent breathlessness without much of fever of cough, more often an interstitial pathology. Recurrent cough and breathlessness, more often a asthmatic attack when it is not associated with fever. So what will be the presentation of recurrent pneumonia? Then you yourself can say right now.
Fever, cough, and breathlessness, sir.
So usually fever will be predominant, breathlessness will be predominant, cough in the absence of bronchiectasis will not be that much predominant. You catch my point? Because
Yes, sir.
pneumonia is a disease of alveoli. Alveoli do not contain much of cough receptors, but alveoli and interstitium are associated with gas exchange. So the manifestation of infection is fever. The
Breathlessness.
manifestation of alveolar involvement is tachypnea. So now you tell me what will be the predominant manifestation, what will be the predominant words from the mother?
Sir, fever, breathlessness, and coughs.
Fantastic.
Good.
That's it.
Yes.
Fantastic. So that's all. See,
We
now
got
is it
Sarath's
possible?
point now. Huh? Sarath's
Very
point
good,
புடிச்சிட்டாரு. Okay.
Very good. So this is how you need to ask a recurrent. You need to ask about fever, cough, and breathlessness, so that you can get a reasonable, good differential diagnosis based on history alone. Okay.
Yes, sir.
Okay. Proceed further.
So, at age of 8, she again admitted and investigated in a private hospital for similar complaints. Her mother was told child has some lung problems and started on some costly medication, which was intermittently given. She hospitalized 4 times till date, once in government hospital, twice in private hospital, and once in our hospital. No history of foreign body aspiration, convulsions, near drowning, measles and whooping cough. No history of asthma and tuberculosis. No history of chronic diarrheal episodes. Next one.
Why did you ask diarrhea? Why did you ask measles? Why did you ask whooping cough?
Sir, diarrhea due to malabsorption. Sir, because of malabsorption, there may be steatoria and it may present as chronic recurrent diarrhea, sir.
Okay, see, simple. Whenever you ask, so now you know you are dealing with a case of, because since you told fever and breathlessness are predominant in each and every admissions, you are dealing with a recurrent lower respiratory tract infection, probably a pneumonia. Number one. Second point, now you need to ask the history so that you can get a reasonable good differential diagnosis. As you told, measles is prone to produce an immunosuppression. Whooping cough is prone to produce a secondary bacterial infection. Second point. Third point, TB more less likely to present with this kind of manifestation. TB is not often a cause for recurrent pneumonia. TB is often a case of persistent pneumonia. Okay. Foreign body aspiration, a very good reliable history. A forgotten or neglected foreign body can present with a recurrent pneumonia involving the same site. Fantastic. Measles, good history. Whooping cough, good history. With respect to diarrhea, you need to ask two things. Is it recurrent loose stools or recurrent oily stools? Recurrent oily stools or persistent oily stools is in favor of dash.
Steatorias.
Steatoria means oily stools. Cause what? Diagnosis, differential diagnosis. Cause, etiology.
Cystic.
No. Which
Cystic
organ is affected, doctor?
Pancreas.
Which organ?
Very good. Cystic fibrosis. Fantastic. Whenever you have recurrent pneumonia and recurrent diarrhea but not oily stools, you will think of what?
Any systemic condition?
Malabsorption syndrome.
Not malabsorption. Malabsorption, the term is often used for non-infective chronic diarrheas. I am asking about recurrent diarrheas with recurrent pneumonias. Both
Some
are
deficiency. Some deficiency will be there. What is that? What disorders? You told one of the causes for recurrent pneumonia. What is that? Gogan?
Yes, ma'am.
What is the causes for recurrent pneumonia? You told some deficiency. Another.
An immunodeficiency.
Immunodeficiency.
Okay, B cell deficiency can present with recurrent pneumonia and recurrent diarrhea. But other things, some forgotten things are. So you have covered many things, but you have not covered upper respiratory tract complaint. Had you added no history of recurrent ear discharge? Had you added recurrent history of running nose? If you need to ask, means what diagnosis you are thinking in your mind, because you had left out recurrent Artesis media. You had left out recurrent or persistent running nose.
Gogan, recurrent running nose இருந்தா என்ன problem வரும்? Correct, yes.
Sinusitis. Which disease will cause that? Whenever you have both upper respiratory and lower respiratory recurrent involvement, what are all the differential diagnoses you will have in your mind?
See, respiratory tract is lined by what, Gogan?
Ciliated.
அப்ப அதுல ஏதாவது
Primary
problem இருந்தா
ciliary discontinuity.
Primary
Fantastic. Very good. So whenever you have both the upper and lower respiratory tract involvement in the form of recurrent or persistent ear discharge, recurrent or persistent running nose, along with the recurrent pneumonia, as you rightly told, primary ciliary dyskinesia. Also immunodeficiency, as we discussed now, immunodeficiency can also present with recurrent otitis media and recurrent pneumonia. So those upper respiratory tract were not discussed here, so you need to add. Okay?
Yes, sir.
Okay, pa. Proceed further.
Next, ma'am.
So is there any upper respiratory tract involvement here?
No, sir.
Is there any oily stools or recurrent low diarrheas?
No, sir.
Okay. Is there any single episode of, now you don't know whether it is pneumonia or not? Okay. Okay. Then proceed further.
Next,
So
ma'am.
this, it involves only lung. That is what you want to say, na?
Yes, sir.
Okay,
Yes,
then proceed for only one episode of some undiagnosed intestinal condition.
Obstruction. Yes, sir.
Okay, then how do you say
Antenatal-
that is
Yes, sir.
obstruction?
Sir, mother told, sir, the child that didn't pass stools.
No, the discharge summary-ல அதுக்கு இருந்துச்சு. அந்த ஹாஸ்பிட்டலோட summary-ல அது இருந்துச்சு. Intussusception.
At what age she developed intussusception?
4 years, sir.
Is it a normal age for a child to develop intussusception?
No, sir.
So see, between 6 months to 3 years, usually intussusception will be there because of Peyer's patch hypertrophy. Beyond that, you need to something else. Okay? So
Yes, sir.
beyond 3 years, whenever a child develops intussusception, think about there might be an underlying structural pathology. Okay?
Yes, sir.
It can be a polyp. It can be a granuloma. Okay?
Yes, sir.
Okay, proceed further.
Antenatal history. Birth order 2. Mother is booked and immunized. Pregnancy confirmed with urine pregnancy cut test. Next, ma'am. First trimester. No history of fever with rash.
No, you skip it. Anything is there in this? Because only 30 more minutes. We have to finish fast. Yes,
No,
next.
ma'am.
இல்ல
No.
relevant இல்லன்னா go to the next history.
Yes.
You
Next, ma'am.
anything you want to ask, sir, Venkatesh sir and Sarath?
Yeah, I
Antenatal
think
history.
we should stick to the relevant history. Here, if you thinking of recurrent pneumonia starting from early age, there are some things which you need to tell from the natal or postnatal history.
Yes, sir.
So you can just say the positive findings. What would you look for rather than telling the entire history? So if suppose a child is having recurrent pneumonia and starting from quite early in life. So what are the history in the antenatal or immediate postnatal period would help you in getting a diagnosis.
Sir, whether the child is preterm or term delivered baby.
Very good. Okay. So what will it tell you? Preterm
So
baby.
whether there was any meconium aspiration, sir.
In preterm or term, meconium is more common aspiration.
Term.
Term baby. In preterm babies, what are the things you expect? What complications or what particular diseases?
So surfactant production would not be there.
Yeah. So probably hyaline membrane disease or respiratory distress syndrome and complications related to it, right? Some babies might be requiring ventilation for a long time, and they develop a particular disease. What is that disease called? If they are administered oxygen for a long time, if they are ventilated for a long time, they develop a particular disease in the lungs. What is it called?
Ventilated associated.
Ventilator.
Some dysplasias, huh? What is it? They don't know, sir.
Yeah, okay, fine. It's like a chronic lung disease. We call it as chronic lung disease. So in babies who develop chronic lung disease, they can have recurrent exacerbations, recurrent breathing difficulty. So that is one possibility. Number two, like if the mother has polyhydramnios and the baby is developing recurrent respiratory tract infection immediately after birth, what will you think of?
In a polyhydramnios, which condition you will get?
Diabetic mother.
Respiratory code or a clue, some respiration associated condition.
Esophageal atresia can present as poly.
Yeah, very good. So esophageal atresia or tracheoesophageal fistula or H-type variants, they can have recurrent pneumonia. And also you should not forget about myopathies. Congenital myopathies, they are at risk for recurrent aspiration, recurrent pneumonia. So they might also have, mothers might have polyhydramnios. They may have decreased fetal movements. That may be another clue. Baby cannot swallow fluid right from the in utero life, fetal life itself. So those are the clues. After the baby is born, if the baby is not past meconium within 24 to 48 hours, then what will you think of?
Meconium.
So what does it tell you? What disease they can manifest later on?
Cystic fibrosis.
Yeah, so they can present with recurrent pneumonia. So those are some of the important things which you can gather from the antenatal, natal, and postnatal history. So those things you would like to inquire. Yeah. Anything there like that in this
No,
child?
sir.
Okay.
No, sir.
Sharath, you want to add anything or?
One more point I want to add. See, majority of the times, many of the antenatal mothers are taken for antenatal scans. So in the antenatal scans, even though you said antenatal scan is normal, you need to say whether the antenatal scan is available or not, because at times they would have mentioned an echogenic bowel or echogenic lung. So when they had mentioned an echogenic lung in the antenatal scan, then it must be probably a thoracic lung malformation. Just now you told me a sequestration can be a cause for recurrent bronchiectasis. Yeah, congenital adenoid malformation can be a cause for bronchiectasis. So in these instances, an antenatal echogenic lung, if they had mentioned, will give you a clue in terms of a congenital lung malformations. Okay? Particularly if recurrent pneumonia involves the same lobe. So always in a case of recurrent pneumonia, particularly if it involves the same lobe, look at the antenatal scan for an echogenic lung. Second point, echogenic bowel. Even though it is not confirmatory, an echogenic bowel in an antenatal scan may be in favor of a possible cystic fibrosis in your differential diagnosis. Okay?
Yes, sir.
Okay, then. Proceed further.
Next slide, ma'am. Next slide, ma'am.
Okay.
Next, ma'am. Next, ma'am.
So one point is also good. Fetal movements perception, because whenever you have recurrent aspiration pneumonia in a young infant, right now your child is 12-year-old. If it is a 12-month-old child or 3-month or 4-month-old child, if the mother is not able to pursue good fetal movements, it may be due to an aspiration pneumonia, probably a neuromuscular disorder. Okay? So definitely, this is a case of recurrent pneumonia in an infant. That fetal movement should have given a good importance. Okay, proceed further.
Yes. Next slide, ma'am. Next slide. Next slide, ma'am. Next. Dietary history. Sir, against the expected of 2060 kilocalories, she is consuming 985 kilocalories. Consumption
Just
percentage
make
is
it
40.
faster. Any
And
deficit?
coming to, yes, sir, deficit of 1075 kilocalories and 13 grams of protein. Sir.
What is the weight of the child?
Sir, child's 29.5 kgs.
12-year-old, no?
Yes, sir.
Expect-
12-year-old
Falls below the third percentile, sir.
falls below the third percentile. Okay, okay, accepted.
Next month,
28 kg, sir.
yes, 29 point.
Okay, right. Do you
Next
really
slide.
think so? Had you used that growth chart, my dear?
Yes, sir. It's in next coming slide, sir.
Okay.
Next slide, ma'am. Summary. A 12-year-old girl with complaints of cough with expectoration for 7 days, fever and breathlessness for 3 days. She has past history of recurrent lower respiratory tract infection on and off since 3 years of age and hospitalized 5 times till date and on intermittent medication for the same. History of consistent decreased appetite and not gaining weight present. She is immunized appropriate for age and normal development in all domains. So I would like to proceed with examination of respiratory system.
Oh, here I think you should give some differential diagnosis, like what Sarath said.
Yes.
From the history, what did you think of in this child? What is the cause for this problem? What is the what is the pathology? What are the likely etiology? What are the complications? That exercise you should do from the history itself.
Yes,
You
sir.
should not just say, I'd like to go and examine. Okay, so you should have some idea about what you are expecting
Yes,
from the history.
Since the child is suffering with recurrent lower respiratory tract infection, the causes for recurrent lower respiratory tract
No,
infection.
you want to characterize the lower respiratory tract infection like Dr. Sharath brought out very beautifully. How different types of lower respiratory tract infection manifest. What is
the other name for recurrent LRA, doctor?
Pneumonia.
Say like that. What is it? It's
Yes, ma'am.
recurrent.
Pneumonia.
Recurrent
Pneumonia.
pneumonia.
Yes, ma'am.
Yeah, you can either say recurrent pneumonia, or you can even say, because this child is also having predominant cough with expectoration of breathlessness associated with fever, right?
Yes, sir.
So in pneumonia, you don't expect predominant cough throughout the course, isn't it?
Yes.
And you also say this is wet cough. So you can straight away bring in a differential diagnosis of a suppurative lung disease here.
Yes, sir.
So when a child has got recurrent such episodes of wet cough, child is not gaining weight, child is having recurrent fever, child is requiring multiple hospitalizations.
Yes, sir.
So all these things tells you, yeah, probably this child is having bronchiectasis. That is correct. So what are the etiology now? What etiological history we got so far from whatever you discussed? Did we explore all the etiologies for bronchiectasis? You talked about infections, isn't it? You talked
Yes,
about
sir.
measles and pertussis history in the past. You talked about contact with tuberculosis. You talked about aspiration, recurrent
Yes, sir.
aspiration, foreign body. You also recurrent infections involving the ears, recurrent diarrhea, those
Yes,
kind of
sir.
information is also not there to rule out immunodeficiency,
Yes, sir.
isn't it? So,
Yes, sir.
so what are we discussing? I mean, what would be the etiology from your history? You should comment on some
Sir,
etiology, right?
Sir, could be cystic fibrosis, sir.
Yeah.
Or-
What makes you think of cystic fibrosis?
Sir,
What
child,
in the history? What are the points for, and what are the points against cystic fibrosis?
sir, child, that is the episode of interception, sir.
Intussusception. Yeah. Okay. Intussusception is one of the feature of cystic fibrosis, but it is little rare.
Yes, sir.
So just because of intussusception, we cannot think of cystic fibrosis, isn't it?
Yes, sir.
Any other clue from history? That oily stool, particularly oily stool, did you explore that history? Like Dr. Sharad was talking about this oily stool.
Yes.
So whether there are any features of malabsorption were able to elicit from the history? Is the child having recurrent lethargy, vomiting in summer times? Is the child becoming very weak, tired easily, becomes dehydrated excessively? So those kind of things also are important aspects to explore in a child with cystic fibrosis. So what are the other manifestations of cystic fibrosis you would expect that you should say? Those things are not there in this child, isn't it?
Yes.
Yeah. Is the child born to consanguineous marriage?
No, sir.
Yeah, so that is also again cystic fibrosis. You all know that it's autosomal recessive, isn't it? Yeah, so it's a genetic condition. So family history of any siblings affected or
siblings
any
is
family
normal.
member. So those things. So that is how we should say. These are the points for cystic fibrosis. Maybe the only point for cystic fibrosis in your child is the presence of that intestinal obstruction, for which they thought there could be an intussusception.
Yes.
Right? But
Yes,
other causes like the child passed meconium within 24 hours, the child was well until 3 years or 4 years. There's no oily stool or feature history of malabsorption, non-consanguine, no family history of CF. So those things are points against you.
Against.
Yeah. So your history should, is it, can it be PCD, primary ciliary dyskinesia from your history? Like Dr. Sharad was mentioning about the predominant upper respiratory symptoms, persistent rhinitis, or child having been admitted in the newborn period for respiratory distress, or a child having associated underlying heart disease. Okay, so these are all clues for primary ciliary dyskinesia. The history is not there, isn't it?
Yes, sir.
So what else can you think of? What else could have led to this problem, bronchiectasis?
So
Can you think of a congenital lung anomaly which you are not, explored completely, probably?
Yes, sir.
It could be an underlying lung anomaly. We are not, because we cannot, from history, we cannot really elicit all the relevant information regarding to congenital lung anomaly. That could be one of the reasons. What else can it be? Can it be acquired immunodeficiency?
Yes.
Congenital, primary immunodeficiency also is a possibility. Primary immunodeficiency. Any neurological conditions you can think of which can present this way, which also has immunological involvement. You have to examine the eyes to look at something. They can also present with some amount of unsteadiness, gait. What condition is that? That history you will not take for this child, isn't it? So when you're talking about bronchiectasis, you should explore all the etiologies in the differential. Then only you will not miss. So what neurological disease can present with bronchiectasis?
That you can find in general examination. Some telangiectasia. What is that?
So
PG questions, sir.
Okay, fine. Okay, fine. So then maybe we can go to the examination. Dr. Sharad, you want to add something?
Okay. Will there be any clue for cystic fibrosis in the immediate newborn period?
Meconium ileus.
Very good. In the same way, cystic fibrosis can also present with recurrent constipation.
Yes, sir.
Okay. That is called distal intestinal obstruction. We don't want to use the term for your level. So it doesn't mean that it can present only with oily stools. That episode of obstruction can be due to a condition that can closely mimic your meconium ileus.
Yes,
okay, that is called distal intestinal obstruction syndrome. So it can also present with the constipation. Which one? Cystic fibrosis. Okay?
Yes, sir.
If the child is having a relatively preserved pancreatic enzymes. Proceed further.
Yes, sir. Next slide, ma'am. Next slide, ma'am. General examination. Consent was obtained. Procedure explained. Child is conscious and dyspneic. Suprascapular, suprasternal, intercostal, subcostal retractions present. Thin built and malnourished. Pallor present. Glossitis present. No icterus, no cyanosis. Glubbing grade 2. No generalized lymphadenopathy. No pedal edema. No external markers of tuberculosis. Next. Can I proceed, sir? Vitals. Pulse 118 beats per minute, which is increased. Regular rhythm. Normal volume. No specific character. No radioradial delay. No radiofemoral delay. All peripheral pulses felt. Condition of the vessel wall normal. Respiratory rate 36 breaths per minute, which is increased. Thoracoabdominal respiration. Blood pressure 90/60 millimeter of mercury in left upper limb in sitting posture, which is normal. Temperature 101 degree Fahrenheit, which is increased. SpO2 90% in room air, which is decreased. JVP not elevated. Next, ma'am. Next slide, ma'am. Anthropometry. Height of the child is 138 centimeter against the expected of 149 centimeter. Next slide, ma'am.
You told weight 29. It is 21, la?
Yes, sir.
You told 29. This is 22 kgs. That's why it is less than third centile then.
Next slide,
Proceed.
ma'am. Which lies between the 3rd and 15th percentile. Next slide, ma'am. Weight of the child is 21.9%, 7 kilogram against expected of 39.5. Next slide, ma'am. Next slide, ma'am. Which lies less than 3rd percentile. Next slide, ma'am. BMI of the child is 11.4, which also lies less than 3rd percentile. Next slide, ma'am. Next slide. Next slide.
So how do you infer? What do you interpret? What is the called if the weight is below less than 3rd centile, if the BMI is less than 3rd centile? What terms do you use to describe them?
Child is undernourished, sir, or malnourished. Sir.
You would like to use malnourished or undernourished?
Undernourished. Sir.
Yeah. So less than 3rd centile, underweight or severe underweight, you can say, depending upon whether it is less than 3 standard deviations or 2 standard deviations. Similarly, for BMI, what is the terminology if it is falling below 3rd centile?
What is the opposite for obese?
Lean.
Gogan? Huh?
Lean.
Yeah, another word for lean is thinness. It can mean thinness or severe thinness, depending upon whether it is below -2 or below -3 standard deviation. Here you're using centile, so it may mean anything. Less than 3 means it may be below -2 or below -3. So you can just call it as thinness. You should know to interpret this. Okay, these are basic anthropometry, right? Okay. So what is your inference here? The height is not affected, only the weight is affected, isn't it?
Yes, sir.
So what do you think could be the reason for this?
Height is between 3 and 15. It is not normal.
Okay. Yeah, it's not normal. It's
all
reduced,
are
but
affected.
it's reduced, but it's not very much reduced. Yeah. Okay. So if height and weight both are reduced, what does it tell you?
So there's stunting, sir, because of chronic malnutrition.
Yeah, it's been a chronic one. It's been over a long period of time. If only weight was affected more than height, it would be an acute problem. Okay. Yeah.
Examination of upper respiratory.
One more point. After anthropometry, whenever you see a child in an adolescent age group between 10 to 19, you need to add SMR staging.
Yes, sir.
Okay, because your underlying disease can predispose to delayed puberty.
Yes.
Okay. So
Yes,
just not much you need to ask whether there is a breast bud or not, whether is there any axillary hair, whether there is pubic hair. Apart from asking history of menarche, you need to add either breast bud, axillary hair, pubic hair, voice change is there or not. Okay. Just add SMR staging, whether it is delayed or not. Because usually in girls, it starts by 10 years.
Yes, sir.
Okay.
And one more thing, before you go to the respiratory system examination, the head to foot examination is very unique and important for pediatrics, isn't it?
Yes.
So in head to foot examination, what all you should see in a child with bronchiectasis? Would there be any clues which will give a diagnosis? I think you mentioned a few. You said no evidence of markers of tuberculosis, you said. But other things you said about the
Retractions.
glossitis, vitamin nutrition deficiency signs you look for, isn't it?
Yes, sir.
You would look for nutrition deficiency signs. What else? Like Madam said, you would have to look for the particular finding in the eyes that you can see for telangiectatic changes. Okay, so in nails, would you look for, apart from clubbing, would nails give a clue to the etiology of bronchiectasis?
So yellow nail symptoms.
Yeah, so those are the things in head-to-foot examination, that is what we are actually looking for. Whether you get some findings which can give a clue to the diagnosis. You should always look for it. Okay. Yeah. Go to the examination.
Examination of upper respiratory tract. Here, no discharge, no deformity, no nasal discharge, no deviated septum, no sinus tenderness. Oropharynx normal. Next slide.
Apart from that, you need to add any
Next
nasal polyps are there or not. Because nasal, if your diagnosis is in terms of cystic fibrosis, you need to see whether nasal polyps are there or not. Okay?
Yes, sir.
Okay. Proceed further.
Next slide. Examination of lower respiratory tract. After taking consent, patient was examined in sitting position. Next slide, ma'am. Inspection. Chest bilaterally symmetrical, no chest deformity. Both sides move equally with respiration. Trachea appears to be in midline. Apical impulse not visible. Suprascapular, suprasternal, intercostal, subcostal retraction present. No dilated veins, no scars, no visible pulsations. Telarchy present. Spine normal. Next slide, ma'am. Palpation, all inspectory findings confirmed. Trachea confirmed to be in midline. Apical impulse is felt in the left fifth intercostal space, 2 cm medial to midclavicular line. Chest expansion, inspiration 62 cm, expiration 59 cm, expansion of 3 cm. Next slide, ma'am. Vocal fremitus is normal all over the lung fields. Next slide, ma'am. Next slide, ma'am. Percussion, resonant note heard all over the lung field. Tidal percussion normal. Next slide, ma'am. Auscultation of the lung fields. We hear vesicular breath sounds with coarse leathery crackles and wheeze present all over the lung field. Next slide, ma'am. Next slide, ma'am. Vocal resonance is normal all over the lung. Next slide, ma'am. Other system examination. Cardiovascular system. S1, S2 heard, no murmur. Abdomen soft, non-tender, no organomegaly. Central nervous system, no focal neurological deficit. Next slide, ma'am. Summary, a 12-year-old girl with complaints of cough with expectoration for 7 days, fever and breathlessness for 3 days, and past history of recurrent lower respiratory tract infection on and off since 3 years of age with decreased appetite and weight gain. She is immunized appropriate for her. On examination, she found to be severely malnourished and has pan-digital clubbing, pallor with dyspnea and tachypnea with bilateral coarse leathery crackles with wheeze heard. Next slide. Provisional diagnosis, bronchiectasis with acute exacerbation of lower respiratory tract infection with anemia and malnutrition.
Again, you need to say probable etiology before you go to investigations. What are
Probably
your
due
different
to
diagnoses? Yeah. Any other DD you want to consider, you should say. All right. So you should summarize all the relevant positive findings in the examination. The child also had some glossitis and all you said, isn't it?
Yes.
Glossitis, he had no evidence of tuberculosis. BCG scar was present, isn't it?
Yes. Yes.
No, yeah, no lymphadenopathy. There are relevant negative things which you need to stress again. Yeah. So only when you tell the differential diagnosis, then you can plan the investigations accordingly.
Yes.
Yeah. Okay.
On the previous slide, you repeat Govind and the diagnosis.
Bronchiectasis with acute exacerbation of a lower respiratory tract infection, probably due to cystic fibrosis with anemia and malnutrition.
Anemia, glossitis, and malnutrition.
Malnutrition.
Only investigate what investigations would give diagnosis, your diagnosis.
Sir, first complete blood count, sir. Where hemoglobin 10.7 gram, which is decreased. Total count is 21,300 cells per millimeter cube, which is increased. In differential count, there is neutrophilia. MCV 71, which is decreased. MCH 21 picogram, which is decreased. Platelets 4,91,000, which is increased, sir. Erythrocyte sedimentation rate 43 millimeter per hour, which is increased.
So what is your understanding based on this investigations so far?
There is anemia and bacterial infection, sir, and marker of inflammation is present, sir.
So what kind of anemia is the child having?
Nutritional anemia.
In nutritional, it could be due to something. Microcytic anemia or macrocytic or normocytic?
Microcytic hypochromic.
Microcytic, yeah, microcytic hypochromic. So, yeah, then ESR is high, it might indicate a bacterial infection or it can even indicate an inflammation, isn't it?
Yes, sir.
The counts can also go up in inflammation. Apart from infection, and there is ongoing inflammation, there also you can have increase in the counts, and neutrophilic leukocytosis can be there. Okay, next, what else did you do? What are the investigations?
Next slide, ma'am. Sputum culture and sensitivity. Pseudomonas grown, which is sensitive to ciprofloxacin and cefotaxime. And chest X-ray, there is bronchopneumonia changes and bronchiectatic changes, sir. Next slide. CT thorax without contrast, there is bronchiectatic changes, both lower lobes. Tree in bud opacity is noted in both lower lobes, which is nodal opacities, and small airway infections present. Next slide. HIV is non-reactive. Sweat chloride is 126 millimole per liter. In genetic testing, there is a CFTR variant, 2052 heterozygous and 1802 heterozygous present, class 1 mutations. Next slide. Immunoglobulin assay, IgE total, it is normal. IgA total is increased and IgG total is increased. And spirometry, there is severe obstructive pattern. FEV1 bar FBC ratio is 0.6. It is 60%, which is decreased.
So there, did you check for reversibility? Did you give some medications, repeat the spirometry? What is reversibility? Where do you get reversible obstruction? Bronchial asthma. Yeah, and the other airway disease where you don't get reversibility is bronchiectasis. So that is how we differentiate. One is reversible, the other one is not reversible.
Non-reversible.
Good. Yeah.
Is there any bedside test to suggest cystic fibrosis apart from doing a sweat chloride test? Bedside test. What about albumin? What about albumin here? Usually cystic fibrosis will be associated with anemia, will be associated with the hypoalbuminemia. Is there any LFT here? Look, what is the serum albumin levels here?
No, sir.
It was normal, I think. Albumin was normal.
Usually cystic fibrosis causes bronchiectasis of upper lobes rather than lower lobes. Whenever you have bronchiectasis involving lower lobes, either it can be due to an immunodeficiency or it can be due to a recurrent aspiration. But anything can happen in medicine. You tell me, what is the bedside test to suggest cystic fibrosis? Bedside test, which in the past 3 years reasonably has been gaining importance.
Very easy to do. You need only a bowl, some water.
Sputum examination.
No.
I agreed here. Sputum pseudomonas is suggestive of cystic fibrosis without any test, without anyone's help. As sir said, you need a bowl of water.
Something with the stools, can you do anything?
Floating.
No. You just need to immerse the hand of the child inside the water, wait for 3 minutes and then take it out and see whether there is wrinkling or not. Usually in children with cystic fibrosis, they develop wrinkling when their hand is immersed in water within 3 minutes. 3 minutes is the cutoff. If they develop wrinkling of the hand within 3 minutes, it is highly suggestive of cystic fibrosis. In addition to the clinical features, like in a child with recurrent pneumonia, failure to thrive, if there is additionally wrinkling of skin when the skin is exposed to water, it can be taken as a clue for underlying cystic fibrosis. Like Dr. Sharath was saying, this is gaining popularity nowadays. Dr. Kabra from AIMS recently had published a paper in which they had found a cutoff time of 3 minutes to identify children with cystic fibrosis. That's why Dr. Sharath wanted to ask you to whether you are aware of that.
So hereafter, whenever you see any case of suspected cystic fibrosis, start doing aquagenic wrinkling test. Okay?
Yes, sir.
I mean, next time when the child comes, we will definitely do it.
Yes.
So what advice would you give?
Even you
Yeah.
can, even without doing, you can ask the mother. You can ask the mother whether during eating, is there any exaggerated wrinkling of the hands? Some mothers are so clear, are so clever in identifying that particular finding. One of our mother told when we were discussing about this aquagenic wrinkling test, she told, yes sir, whenever he eats, we find that exaggerated wrinkling in the hands, sir, that takes long time to go, sir. One more point, a month back, a mother came and it was a case of cystic fibrosis. The child was doing reasonably fine. But when we asked the mother whether any family history of similar diseases, she said no. So we did aquagenic wrinkling test to demonstrate to our postgraduates. You know what the mother had done? She went home and practiced the aquagenic wrinkling test for her and practiced the aquagenic wrinkling test for the father. And the next day she came and told us probably father should be the carrier. So genetic mutation is done at bedside. And she told it comes within 1 minute, sir. You people were discussing with the
3 minutes.
EG. She told the carrier should be the father. See, see for what kind of information
next
you are
time
getting.
சண்டை பிடிக்கிறதுக்கு ஈஸியா இருக்கும். உன்னாலதான் வந்துச்சு.
So this is a simple bedside test. Please do not forget. Okay?
Yes, sir.
Okay.
Okay, sir.
Yeah. So how do you treat this child now? Since you arrived at a diagnosis, what is the cutoff for sweat chloride for diagnosis of cystic fibrosis?
Sir, less than 30 is normal, sir. 30 to 60 is borderline, sir. Above more than 60 is cutoff, sir.
Yeah. So how many values you should have? One value is enough or two values? Ideally, you should have two values done on 2 separate days. And if both values are more than 60, it is confirmatory of cystic fibrosis with a given clinical history. Okay. With the history and the sweat chloride, it is enough to make a diagnosis. There's no need to do even genetic studies or mutation studies. But you have already done mutation study and you found out class 1 mutation. So now class 1 mutation means, you know what class 1 mutation means? It means it does not, respond that well to
prognosis is not.
Yeah, there are newer modalities of treatment. So ultimately, what you are left with is only improving nutrition, preventing infection, teaching them proper chest physiotherapy so that the child does not get recurrent exacerbations. Yeah, giving proper antibiotics to eradicate the pseudomonas. You said you identified pseudomonas in the airways, so we need to give a eradication regimen. Antibiotics like.
Would like to know she's not having steatorrhea really.
That's what.
She's around 12 years old.
Yeah, so failure to thrive, and what could be the reason for?
What simple first line lab test to look for steatorrhea? 1, asking oily stools. 2, it sticks to the pan. 3rd point, what simple test you will ask the pathologist to do or a microbiologist to do? Stool for dash. Stool for fat cells. Even though it is not a gold standard method, identifying plenty of stool for fat cells is an indirect evidence for cystic fibrosis to say whether pancreatic insufficiency is there or not. Okay? Cystic
Yes, sir.
fibrosis, unless otherwise proved, majority of them will have pancreatic insufficiency by this age group. It is surprising to see a child with involvement of this bronchiectasis, but without any pancreatic involvement. Next
No,
time,
this child, the problem is because of COVID and all that, she never comes regularly for checkup. So private lo poi pancreozymin the intermittent the child is getting it.
That
Child
history,
is
I think,
on.
yeah, that history they told that they're getting some costly drug. I was wondering what costly drug the child was getting. That
So
was a
அவங்க
direct clue.
இங்க ரெகுலரா வர்றதில்ல. அவங்க work place தகுந்த மாதிரி insurance availability will be different.
Because in this case, apart from reducing the respiratory tract infection, you need to say, you need to add enzyme replacement therapy in this child so that whenever they eat something, it will be absorbed into the intestine. Because enzyme replacement therapy in the form of, as you said, either creon or pan lipase, that is lipase enzymes, should be given. So only you can improve the general condition of the patients, so that by simply giving enzyme replacement therapy, you can improve the nutrition and you can improve the general well-being. Thereby you can decrease the further incidences of recurrent pneumonias. So it is not treating bronchiectasis with, not treating these exacerbations with the antibiotics alone. Improve the nutrition with the enzyme replacement therapy. Okay.
Yes, sir.
First point. And one more point apart from enzyme replacement therapy. Whenever you see any case of bronchiectasis, to avoid further exacerbations, what else you will advise the parent to do at home?
Sir, hypertonic saline inhalation, sir.
Followed by
inhalation of salbutamol and cupped percussion
chest physiotherapy. So do not forget about enzyme replacement therapy. Do not forget about chest physiotherapy. Okay?
Yes, sir.
And vaccination to prevent
Annual influenza
infections.
vaccine.
Yeah,
Yes.
annual influenza vaccine,
Right.
pneumococcal vaccine if the child
Yes.
has not received pneumococcal vaccine. Yeah. Good presentation. Very nice. You did a good
Over
job.
from our side, na? Thank you.
Yeah, yeah.
Sir,
Yeah,
it's over from our side, sir.
Yeah,
On-
sure. Thank you, students, for your wonderful
Thank you, sir.
presentation. And
Thank you, sir.
thank you, madam, for
The
arranging
students
this.
are very lucky to have both of you as moderators.
Oh, Sharath. Sharath is the one
we
who
are
took
lucky
away
enough to have these students, madam.
Yeah, good, very good.
So on behalf of IAP TNC, really thank Dr. Sarath and as well as Dr. Venkatesh. Sarath அந்த குழந்தைகளை கையில பிடிச்சி சொல்லி தர மாதிரி சொல்லுவாங்களே அது மாதிரி டாட் லைக் எனிதிங்.
ஆமா, ஸ்லேட்ல ABCD எல்லாம் எழுதி தருவோம்ல அந்த மாதிரி சொல்லி கொடுத்துட்டாரு.
I think this is a way you have to teach the undergraduate students. I think both are really wholeheartedly really appreciate Dr. Venkatesh as well as Dr. Sarath. Both they did very well. And
I learnt a lot, sir, from A to Z of respiratory system. From this thing, you know, from the types of cough and this thing and what organism you have to suspect. I am totally this thing, you know, learnt a lot of things, basics A to Z. I was typing and suddenly the internet went off. So again, this thing. Thank you so much.
Yeah, and I think Dr. Soundarajan is there. I am a judge.
Judges, yeah.
No, I was not there for full time, but anyway, I congratulate the student. They presented very well. Rather than the students, I think Madam said they are lucky to have the moderators today. Like our Solamari, you know, this is the way to teach undergraduates. So not terrorizing them. So gently, you know.
There is no terrorism. Yeah.
No. I'm saying we should not terrorize them. You know, today it was very wonderful and, you know, okay. Okay.
Any of the judges are Dr. Boma, Dr. Selvakumar, Tanjavur, as well as any.
Selva Kumar was here. He spoke something.
Dr. Selvakumar. He is not there. Yeah. Okay.
voice கேட்கலையே.
They could not name it. I think at this time they could not name it. Okay.
2 hours போனதே தெரியல டாக்டர் ராஜேந்திரன். அந்த இல்ல இல்ல எப்படி இருந்ததுன்னா ஒரு த்ரில்லர் படம் பாக்குற மாதிரி இருந்துச்சு. எனக்கு டைம் போனதே தெரியல.
Really
அழகா சொன்னீங்க.
சரத் பாலாஜி
கதை திரைக்கதை வசனம் டைரக்ஷன் விவர் இல்லையா பாலாஜி and வெங்கடேஷ். Make it interesting.
Really
Balaji's presentation was very awesome. I enjoyed his the way of dealing with the undergraduates. So I also learned a few things from. Like I said, I came to learn and I learned a few things.
Thank you sir. நம்மளும் learners தான்.
Yeah.
Gohan, your comment please. Yeah, student. First of all, you have to ask students, how was it?
Yeah. Sir, learned the idea how to approach with the history first, sir. Before with the history. We should start the probable etiology and the complications before going to examination, and what else we have to do to receive the correct diagnosis. I learned, sir. Moreover, I learned that we have to concentrate more on history, and we have to make a diagnosis within history itself.
Very good. Yeah, thank you. I think it's a good to Dr. Sarath as well as
Sharath has achieved this thing, aim, objective.
Okay. And Dr. Sugandhi madam, your final conclusion.
Yeah, today is a very great day. I really enjoyed அதான் சொன்னேன் டைம் போனதே எனக்கு தெரியல. I thank Dr. Venkatesh, Dr. Sarath. I thank you a lot, and I thank Dr. Rajendran for this wonderful opportunity. இதே மாதிரி நல்லா பண்ணுங்க எப்பவுமே.
Thank you, madam. And actually, I want to tell, and I think February 18th or 19th, or second Sunday or third Sunday, Dr. Rama Chandramohan is going to organize the undergraduate one-day program. So almost a 2-day program. That means 4 hours for exam-going students of final year MBBS students. Half an hour to 45 minutes, their case presentation, what are the common cases you are going to handle. I think from various institutions is going to organize. I think IAP TNSC will organize this event, and Dr. Rama Chandramohan will be a convener of this program, and we will let you know that exact date, and I will announce it. Okay. I thank Dr. Sarath and Dr. Venkatesh sir, and I think they have done really very well. And next week, actually, postgraduate teaching program also, it's happened to be a bronchiectasis from ICH they are going to present. And I think Sarath will talk that.
It is, sir.
Okay, at the postgraduate level. Yeah, you happen to be like that. Thank you.
Thank you so much.
Yeah.
Thank you.
Thank you.
Thank you, Srini sir. Suganti ma'am.
Thank you.
Thank you, all of you.
Thank you, sir.
For the wonderful decisions.
Thank you.
Bye, sir.
Bye.